The sound is not coming. The sound is not coming, Ashti. We can please share.
Apologies, just allow me a moment.
So this is an initiative that we started around 5 years back, Vijay, and everyone in the audience as well. This was started as a rehabilitation project aftermath of the 2013 floods. It's a big medical van which contains a pathology lab, a technician for X-ray machine, a doctor, two compounders, one person for the local mobilization, and a driver. And all these teams travel for 24 days in a month at a stretch, organizing 24 health camps in various parts of the northern districts of Uttarakhand. We ran this for 5 years, and after that, now we have also opened 2 more mobile medical units, one in Tripura and one in Alwar. And you also have one running in Tamil Nadu and Kerala, the border of that, for around 2-3 years. So we have 4 vans on 4 very different geographies: Rajasthan, Uttarakhand, Tripura, and Kerala. And all of them, the whole objective is that we will run these camps in villages with the nearest PHC is more than a few kilometers away. And these camps would be run on a schedule. So you will know that every second of the month, I will get my doctor, I will meet my doctor and take my medicines from there. In the meanwhile, if you want to connect the doctor is just in one of the neighboring villages. That's where the health camps are structured. And good amount of ground mobilization goes into it. And a great deal of patients really look forward to these camps because these tests become so expensive when they go to cities. And there is a doctor coming in, and the doctor also builds their own connect with the local community. It's more like a family doctor that gets. The biggest help comes in the form of maternal health. Because in maternal health, people will go to the cities 3-4 times just to check if everything is okay. If the doctor comes to the village, so that entire day that goes in going to a new city, waiting in the line, finally seeing a doctor, and then coming back, the whole day gets saved. Because a doctor is there to see if the mental health is all right, and they can wait for a few days to formally shift to hospital for the delivery. Ashwin, can we quickly share the video? Over to you, Shanti.
Namaskar to everybody. And I take this opportunity to welcome Dr. Abhay Bang, who is an Padmashree awardee and has been working in tribal areas of Gadchiroli and Chandrapur districts. And it is decades of service and understanding the public health in those areas. Of course, while we were chatting earlier, he recalled the sickle cell problem that is widespread amongst the tribals all over the world, as a matter of fact, but more so in central India region. And he has been working with that, working on it for all these years. Both of them are devoted to the social service, as a matter of fact, and are a renowned couple working on the same project together and distinguished as such. Abhayji, our Sewa Samwaad is a monthly lecture, and we have invited a galaxy of them till now, starting with Bindeshwar Pathak ji and Padmashree Fulbasan Bai, and all of them. Vandana Shivaji, Rajendra Singh ji, the waterman, and so on. And we look forward to the best of the knowledge and experiences to be shared by the presenters, by the speakers. And I will now take this opportunity to welcome you all, the audience also, to this wonderful lecture. We are, as you have seen earlier in the short clip of a video, we are working in interior areas, far-flung areas, till the China border in Uttarakhand. But where Dr. Abhay Bang and Dr. Rani Bang work, it's no less difficult area. I had the good fortune of attending Baba Amteji's run, Ananda Mela, twice, and had the exposure to Aheri and Gadchiroli, those areas. So with that, I again welcome you all, and especially Dr. Abhay, and I'm sure we'll have good intellectual input as well as his experience that will all motivate us. Namaskar and thank you.
Namaskar, Abhay, and it is indeed our pleasure at Sewa Samwaad to welcome you today. A person of your stature and the work that you have done actually does not need too much of an introduction. But as they say, sometimes you need to have and complete some formalities. So I will take this opportunity because I've got this chance to really welcome somebody like you. So dear audience, growing up in Sevagram Ashram of Mahatma Gandhi, Dr. Abhay Bang has always been motivated with the Seva Bhav, an idea of serving others. It is our privilege to have the Padmashree awardee and globally renowned Dr. Abhay Bang with us on Sewa Samwaad today. He was an outstanding achiever in the university. He won 3 gold medals. But subsequently, he, along with his wife, Dr. Rani ji, founded a voluntary organization, Search, Society for Education, Action and Research in Community Health. That organization has been working with people in 150 villages to provide community-based healthcare programs and conduct research. He has in fact revolutionized healthcare for the poorest people in India and has overseen a program that has substantially reduced infant mortality rates in one of the most poverty-stricken areas in the world. His approach to treating newborns has been endorsed by global organizations such as the WHO and UNICEF. The idea of Arogya Swaraj was introduced by Dr. Bang, where he talked about people's health in people's hands by empowering individuals and communities to take charge of their own health and thereby help them achieve freedom from disease as well as dependence. It will be our pleasure to hear from you, Dr. Bang, about how individuals can take charge of their own health. Over to you, Doctor.
Thank you, Mrugangji, and respected Shyamji Parande, Mrugangji, Sewa International team, and the 27 participants in this Zoom call. I'm indeed honored as well as delighted to be talking to you. You are not only, you not only talk, but you do, you act. And that's why your approach and all of you have a special place for me. As Mrugangji just now said, what I intend to share with you is this story of In Search of Arogya Swaraj. And let me come to it. The challenge of healthcare in India. Am I properly audible?
Yes, Abhay.
Yes.
Okay. The challenge of healthcare in India is how to provide accessible and affordable healthcare to 1.4 billion people living in nearly 1 million villages, hamlets, and towns. Huge number, astronomical number, diversity, distances, difficulties, impoverishment, and through all this, the challenge of all range of healthcare is now added to that is Corona. So that's the biggest challenge that we have. So what I propose to share with you today is what is our story in search of Arogya Swaraj. I'll also propose in the latter part the healthcare solution which I think are more feasible and desirable for India. And finally, we will end with what can I do? As an individual, what can we do? My story begins much before I was born. My father was a university gold medalist from Nagpur University, and he was a freedom fighter. He was a professor in one college started in Wardha by Mahatma Gandhi and Jamnalal Bajaj. When freedom was about to come, the then government of India decided to send this young freedom fighter to the US for studying economics further. My father got admission in the US University, scholarship, travel documents were made. 1 week before his scheduled departure, he went to this place. Many of you will recognize this is Bapu Kuti, Sevagram Ashram. Gandhiji was sitting inside Bapu Kuti on the floor. My father went, he was 28 years old, young man at that time, bowed to him. Bapu looked up and asked, how do you come, Professor Bang? So my father said, Bapu, I am released from jail and now I am going to the US for studying economics further. I seek your blessings. Gandhiji looked at him for a few seconds and then uttered only one sentence. He said, and because he said in Hindi, अर्थशास्त्र सीखना है तो अमेरिका की बजाय भारत के देहातों में जाओ. And that's it. He continued his writing. My father quietly came out. And right outside Bapu Kuti, in this very place, he tore away his scholarship and travel documents, cancelled his trip to the US, and within 1 month, along with his students of economics and his young wife, he formed a commune in a nearby village in Wardha district, started living like a farmer in a village, learning economics by living like a farmer. Nearly 45 years later, when Rani and I decided to start work, to work for health of rural areas in India, but more so in Maharashtra. We chose this Gadchiroli district. Many people ask, why? And one answer is that those words of Mahatma Gandhi were still ringing in our ears. Bharat ke dehaton mein jao. And so we decided that let's go to the most remote place in the Maharashtra, which needs us most as the doctor. Naturally, that place was Gadchiroli, and that's how we reached Gadchiroli in 1986. Now, Gadchiroli, as many of you might know, is the poorest and most backward and remotest district of Maharashtra, nearly 1,000 kilometers away from Bombay, bordering with Chhattisgarh border, the red area that you see. About 40% population is tribal, so there are nearly 5 lakh tribal there. Usually, rural tribal people live in this kind of hamlets, 30, 40, 50 households, and separated by huge distances. Madia Gond tribe is the resident in the forest in those villages. They still continue to live, and 35 years ago, they very much lived with their traditional ways of life. Paddy cultivation was the main occupation, which kept people busy for 4 months. Rest of the months, they collected forest produce and survived. Outside every tribal village, you would find under the mahua tree these kind of wooden deities, Marai, Gadevata. These are all Devi Devata who specialized in helping people, helping sick people. When there is no healthcare, people still need some psychological satisfaction. They can't let their near dear die without having done anything. So then you need this kind of gods and worshipping them with, so that at least, if not medicine, that provides at least psychological consolation. And intermittently, there used to be bomb blasts because of the Naxalite movement. Such was Gadchiroli district when we arrived here. And within 1 week of our arrival, in the very first month, there were huge floods. Our house was separated from rest of the world for 7 days. And that's how our search of healthcare for rural tribal people began in Gadchiroli in 1986. Now, for the past 25 years, we have, in the midst of forest, we have settled our headquarters. We call it Shodhagram, a village in search of healthcare for rural people. And we, along with nearly 100 our colleagues and workers, we together live in this campus. And we named our organization SEARCH, Society for Education, Action and Research in Community Health. And the logo really tells the purpose. The woods are lovely, dark and deep, but we have to find the solution for healthcare. We began with that problem, how to provide healthcare to 1.4 billion people living in 1 million locations. That's what we are doing, trying to find a path, trying to find an approach to provide healthcare. Now, in the very first month of our starting work in Gadchiroli, this girl was sent to me as a suspected case of heart disease. As a physician, I examined her and I suspected that she doesn't have heart disease. She probably has something else. So I established the sickle cell test and reported the first case of sickle cell disease in the district. She had sickle cell disease. You can see the swollen abdomen, pale tongue. You can't see there, but she had jaundice also. So this was the first case of sickle. Now, though sickle had been described elsewhere in central India, but nobody had bothered to do the testing in Gadchiroli district. So I happened to find the first case. That was very exciting for a young doctor, recently come back from the US. Oh, I have found something new. And in that enthusiasm, these are the sickle cell as you see under the microscope. And there are 2 types of sickle. If you get sickle gene only from one parent, you don't get any disease manifestation. On the contrary, you get protection from malaria. So it's partly protective. But if you get sickle gene from both the parents, then only you get severe disease. This happens in a very small minority of the people. Most of the people have sickle trait. Most of the sickle people have sickle trait. So it is asymptomatic. We did district sample survey, took blood sample from various caste and various communities, various parts. People gave blood sample. And we found that 15% of population in Gadchiroli had sickle cell trait. And less than 1% had sickle cell homozygous. Both parents have a transmitted gene, which is troublesome. So actually, a disease which would bother the people was less than 1%. These findings were published in research journal. Maharashtra government honored me with a state honor. Maharashtra government announced, health minister announced that in response to this, we will start a tribal medical research center in Gadchiroli under search. Tribal medical research center did start, but it started in Pune, where there are no tribals. But the doctors and researchers did not want to go to Gadchiroli. They wanted to live in Pune. So the tribal medical research center went where doctors wanted to live, Pune. So we went to tribal leaders in Gadchiroli, in villages, and said, look, we found sickle cell in you, but the center has been established in Pune, so you should do something, you should demand. Old tribal people looked at us in a very flat way. And they said, doctor, did we ever tell you that sickle is our problem? You came and asked for a drop of blood. We thought, why disappoint this young doctor couple? So we gave you a drop of blood. Sickle is your problem, not our problem. You solve it. It is your problem. We realized that we had committed a blunder. We had thrust upon people our intellectual curiosity. People didn't feel that sickle was their health priority. But without inquiring about that, we were intrigued, excited by this new finding. And in that heat of enthusiasm, we had done this district sample survey. But finally, though it gave us honor and publication, but people rejected us. And we learned the first lesson and decided that hereafter we will not do any research, any health program which people don't need. What we learned was that research should address the need of the community I work with and not the research community I report to. Most of us, we medical doctors or researchers, when we work, we are usually thinking about publications, conferences, presentations, claps. But if that ends up in really digging out problems which people don't need, we learned this through this blunder. And as I said, decided that we must work on what people need and not what we want to work on. All of us who have got professional training have this a prison. We look at the world through our professional prism. What I know, I'll offer to the people, but people may not need it. People may need something else, but you never ask the people as to what do you need. And so we face this question bluntly. What are the health priorities of people? What do they need? And so to get this answer, Rani and I started going from villages to village, sitting with the people around night fire, talking to them, asking them. And then finally, we convened a tribal health assembly in which people expressed what their health priorities were. And finally, we conducted formally voting. As you can see on those boxes, diarrhea, aang dukhne, kambar dukhne, malaria. These were the problems which people had expressed in that convention. And then people voted and finally look, what were the people's priorities? Malaria, number 1. Back pain, number 2. Alcohol and alcoholism, number 3. And our children die. Now, for the past 30 years, we are usually mostly working on those 4 priorities. We have been able to solve some of these to some extent. And so I intend to share with you only the last story of the last one. People said their children die. So we began by measuring the problem. People just said our children die, but how many? Why? We don't know. So we set up a sort of laboratory of 100 villages with nearly 100,000, 1 lakh population, measured, recorded every birth, every child death. And we found that in the first year of this measurement, in 1988, infant mortality rate. Now, IMR is a very common way you measure health status of the people. If 1,000 babies were born, how many died within 1 year of birth? That's called infant mortality rate. For example, in Kerala, it is around 10. In the US, it is 4. In Gadchiroli, we found it 121 in 1988. And why did children die? One of the main cause was childhood pneumonia. So when the child develops pneumonia, it becomes hypoxic. It becomes miserable, gasps for breath and for oxygen. Who diagnosed in the village? And especially in the remote areas like Gadchiroli. No doctor, no X-ray machine, no stethoscope, no medicine. And that's why pneumonia was #1 killer in that area when we measured it for the first time. So we ought to provide antibiotic to these children, but how to diagnose pneumonia in villages? Fortunately for us, a young researcher from Australia had developed this simple criteria that if you count breath, how many breaths per minute a child takes? If a child with cough, count the respiratory rate, and if the rate is more than 60 in a baby of 2-month-old, it is pneumonia. If it is 50 to 59 in 2 to 12-month-old, it is pneumonia. So I developed this simple equipment. We called it breath counter. There is a sand timer and there is this abacus. 5 beads in one row, 6 beads in another row. One for the newborn babies. With this 1-minute sand timer and with this abacus, even illiterate women, illiterate dais could diagnose pneumonia by counting respiratory rate with this abacus. 1 bead moved for every 10 breaths. If the red bead moved before the 1 minute was completed, it is pneumonia. Simple. When we compare this apparatus by training the eyes to make diagnosis of pneumonia on 50 children with cough, I examined with stethoscope and X-ray. They diagnosed with breath counter. Their diagnosis was 82% correct. So an illiterate woman, illiterate dai could become at least 82% like a doctor as far as the diagnosis of pneumonia in children is concerned. Thus empowered dais, village health worker whom we started calling Arogya Doot, messengers of health. Those who were literate, 7th pass or fail, we trained them as Arogya Doot, and through them we started treating pneumonia with antibiotic. Look, before this treatment was made available, those who developed sign symptoms of pneumonia, 13.5% of them died amongst children. And after this treatment made available through village health workers and dais, in at that time 58 villages, with treatment the death rate steeply came down to 0.8 and then subsequently 0.5. And this has been continued from 1988. I am showing here only up to 2003, but even till today, this treatment is continued, and death rate from 13.5% has dropped to less than 0.5% for nearly 30 years. That's what can happen if you select the problem of people's priority. People said our children die. Can you do something? And a simple solution, and empowering a village woman, village Arogya Doot, and give her birth counter, or if she was literate, she could count respiratory rate with the wristwatch and make diagnosis. treat with cotrimoxazole, a very simple, cheap antibiotic, and look at the difference. With this approach, the infant mortality rate reduced from 121 to 80, but then subsequently it wouldn't budge. Why? Because now the remaining mortality was mainly amongst newborn babies. Now these newborn babies, especially in villages, are very fragile, vulnerable, very delicate human beings. They are usually taken care of in this kind of setting. Now this is one village delivery room in village called Murza. You can see mother is still lying on charpai, and this newborn baby, low birth weight, the grandmother is giving oil bath. But this baby might become cold, hypothermic. And look at the cow dung plastered floor and her dusty soles. So billions of bacteria within 3-4 inches from baby's bare body. So baby can get infected, can develop sepsis. Sepsis is a very fatal disease. How can you provide newborn care to such children? Because tradition didn't allow those mothers and those babies to be taken out of that hut. There were taboos. Nazar lag jayegi, jadoo tona ho jayega. And so we decided that how far a mother on foot can walk with a sick baby in her arms. Healthcare must be available within that distance. This is a famous dictum from when China decided its health policy in 1950. They decided this as a dictum, very beautiful one. And those babies and mother were not allowed to leave the delivery room. So we said, okay, if they can't come to hospital, hospital means medical science must go where they were, and they were inside home. So newborn care must go to home. And that's why we designed this new approach called home-based newborn care to provide newborn care, neonatal care to rural newborn babies who had the highest death rate in the human life through trained village health workers. Now she is Kajubai, a Dalit woman from village Ambe Shivni. Kajubai was 7th standard fail. Her husband was alcoholic. He also had tuberculosis. But this woman, excuse me, had tremendous passion for doing something for her village and for learning. So we selected Kajubai and 39 such women, one from each village from 39 villages. We selected on their certain specific criteria and attributes and qualities, and we trained them through a training program of 36 days, 3 days every month for 12 months. Work in your own village and learn while working in your own village. And then 3 days training in search. Again, go and work in your village. Learning and working were combined together. At the end of 1 year, they became expert village level neonatologists. I'm not boasting. We invited 10 topmost pediatricians of India to evaluate them, including Dr. Vinod Paul, who is currently Niti Aayog member, his guru, Dr. Meherwan Singh, who was chairman of pediatrics at All India Institute of Medical Sciences, and 10 such eminent pediatricians. They evaluated these 39 workers for 3 days. And finally, Dr. Meherwan Singh said that these semi-literate women from Gadchiroli, the trained Arogya Doots of Search, they know about newborn care more than my medical graduates of All India Institute of Medical Science. And with that certificate, we allowed them to provide newborn care at home in villages. That care involved health education of mother using flip chart, and the Arogya Doot attending home delivery, then examining baby, making 7 visits to baby, taking temperature, weighing the baby, helping mother to take care of baby, preventive care, health education. And if baby was low birth weight baby, twin babies, you can see not only they are thin, but houseflies sitting on their body. These babies would easily get infected, develop sepsis. So we had no electricity, no incubators in the villages. So we used to keep them babies warm like this. And if babies develop neonatal sepsis, serious infection, then treat with antibiotics. Same Kajubai is treating a sick newborn in her village. Now, we were closely monitoring its effect. This was done as a controlled experimental trial. So the yellow line that you see shows us the newborn mortality rate. If 1,000 newborn babies are born, how many die within first 1 month? That is called newborn mortality rate, NMR. It was around 60. And for the next 10 years, as you can see with some random fluctuation, it has remained around 60, which means the rural healthcare in India remained like this. This is our government program area, the yellow line. And in those 39 villages where we introduce Arogya Doot, providing home-based newborn care, that is with the blue line, there look at the NMR, it was 62 in 1993-95. And with home-based newborn care is steeply declined. Within 3 years, it came down to 26. And then the experimental trial was over and it was continued as a service program. I'm showing it here up to 2003, but then it has subsequently continued. 70% reduction as compared to the government program area. Begin with, at the baseline, they were very closely similar. Now, reducing newborn mortality is supposed to be very difficult. WHO guidelines at that time were a sick newborn. Oh, don't do anything. It's very difficult. It's very serious. Refer to the hospital. But where was hospital in Gadchiroli? The nearest hospital with newborn care was 100 kilometers away in Chandrapur. And these babies were not allowed to even step out of the home delivery room. By providing care at home, in that home delivery room, in that newborn care room, by community health worker, the NMR reduced by 70%. I can tell you that if any new technology, any new medicine reduces NMR in the US by 5%, it will become a national headline. And here these women had reduced it by 70%. And the infant mortality rate, we go back to the earlier one, which was 121. This is death up to 1 year of age. That was death up to 1 month of age. Infant mortality rate, which was 121, with pneumonia treatment, it came down to 80. With home-based newborn care, it finally came down to the level of 30. And coincidentally, Government of India selected this 30 as the national goal to reduce an IMR to the level of 30 by 2010. These women in Gadchiroli had already achieved it much, much earlier. With what? Same Kajubai 20 years later. These are the simple equipments that she carries with her. These we have given her. This cost totally about 2,000 rupees. And with these equipments on her shoulder bag, Shabnam bag, and with knowledge in her head, skills in her hands, and compassion in her heart, she goes from home to home and she literally becomes a mobile newborn hospital. She is the hospital. She is the newborn ICU. And again, I am not exaggerating. The death rate in the hands of these community health workers is comparable to the death rate of secondary level hospitals in urban areas. This is the miracle. This is a miracle of empowerment. This is home-based newborn care logo, symbol. Look, this rural home or hut was dark. And this woman was alone, mother. Her baby was sick. But open that window, one window of knowledge, one window of skill, training, knowledge, medicine. And with that, the woman becomes empowered. And the empowered woman on her hands can lift the entire family, entire village community and take care of the newborn baby and save their children. This because it was a controlled trial designed like a research experiment in the laboratory of nearly 87 villages. It was published in the Lancet. Lancet, as you know, is the world's leading medical journal, British medical journal. Not only Lancet published it, but several years later, the Lancet selected this Gadchiroli research paper as one of the vintage papers ever published in the Lancet, 180 years history. So service, but while doing service, if you also incorporate rigorous science to test your service programs, you can come up. Most often you fail, and that is acceptable. But once in a while, you come up with a solution. If it is backed with evidence, with data, with power of scientific methods and research, it makes huge impact, to the extent that in 2011, Government of India selected this approach as for national scaling up. And it selected, Planning Commission selected this as the mainstay of India's strategy to reduce infant mortality. And operational guidelines under NRHM were prepared. We were asked to develop strategy to train 9 lakh Ashas in India. So these are the various training materials that we develop. Even the Asha model is partly based on Gadchiroli experiment. Planning Commission had sent a special team to study this approach. We designed a training strategy in which we trained the national trainers, state trainers, and then they went and they trained 5,000 district trainers, and they trained 9 lakh Ashas. That's how through a 3-stage model, but maintaining the quality rigorously, and these kind of training aids, 9 lakh Ashas have been trained to provide home-based newborn care approach, which you saw with Kajubai. So there are now 9 lakh Kajubais in India. They are called Ashas. And 2 years ago, Government of India informed me that last year, 1 crore and 10 lakh newborn babies in rural India received home-based newborn care. And that has helped in rapidly bringing down infant mortality rate in India, except for Kerala and Tamil Nadu, where infant mortality was already very low, so they didn't need this. All other states in India have incorporated home-based newborn care in their rural health mission. So this is the story of evolving search model of healthcare. You would see that the model has to be appropriate to the needs and the culture of the people with whom you work. You are not trying to design model for the population in the US. You are trying to design model for your people in India, and those people especially who are not reached, who are needy. It must serve the weakest and most needy. It has to be low cost, but high quality. Low cost because you should be able to give it to large number of people, but low cost doesn't mean poor quality. As I said earlier, our all solutions and their efficacy, effectiveness compares very well with the hospitals in urban area. It should be accessible, and so it must be close to people's home. It should be effective in reducing problem. Otherwise, I provide service. I say that I have treated thousands of patients. Yes, but how did it help? Did it reduce the health problem on which you are working? Service without effect might give me personal satisfaction, but does it solve the problem? So it must be effective in reducing the problem on which you are working. It must empower the community. If it only empowers doctors and hospitals and multinational drugs companies and diagnostic chains, then you have only increased their business. Knowledge, medical knowledge and empowerment must travel from wherever it is to the people in rural areas where it is needed. And finally, if it is done with research and evidence-based, it makes much larger impact, much beyond where you are working. So this is search model of healthcare. We call it Arogya Swarajya model. Why? I'll come to that. The quest for healthcare in India, how to provide, that was our original question with which we began this journey. Now, healthcare cost in India, government and private payment which people make for healthcare, medical care, that's about 5% of the GDP. Total medical care, private as well as government together. which is about $100 per capita per year. Now, the US medical care costs are $9,000 per capita per year. 90 times more than what we spend in India. So there is a huge difference in the money available for healthcare to the people. India reality and the US reality. Now, if that is the difference, the medical care models from the West are wasteful. You cannot imitate American model of healthcare and try to provide healthcare to Indian people with the American way of medical care. They are wasteful. They are impossible to sustain financially. Who is going to pay $9,000 per capita, not per patient, per capita in the entire population? It would be nearly 20 times India's total GDP if we provide that to the whole of India. And so, what is the alternative vision? The vision is that the best way of providing universal health care to 1.25 billion, now 1.4 billion people, population, is not through hospitals and doctors, but to generate universal capacity to care for health. Every human being, every village, every community needs healthcare. No escape from it. So you must diffuse the capacity as much as possible. Means empower the people, empower somebody in the community so that community can provide care to itself. Village healthcare needs, we have done studies in Gadchuli that shows us that there are 6 units of community healthcare which are required in each village of 1,000 population. So 2 community health workers will have to work for 6 hours per day to provide comprehensive village-based. These women, naturally, Government of India has already called them Asha, and another person should be a man, Ashok. So a team of Asha and Ashok, one who removes Shok. So a team of Asha and Ashok in every village. So we need 1 million Ashas and 1 million Ashoks. They can produce more health returns, dividend, health results than 10 All India Institutes of Medical Sciences. The AIMS and AIMSs will remain limited to big cities. They will cater to the people, undoubtedly, but only a small proportion of the population. But most of the often you will see government announcements to the focus and news about the AIMS, not about the Asha, not about the Ashok. But only Ashas and Ashoks can address the need of how to provide health care to 1.4 billion population. And the approach to provide health care must not be health dependence, but make them swasth. जो स्व में स्थित है वो स्वस्थ है. So how to make them swasth? The very definition of health in India is freedom from dependence. डॉक्टरस्थ नहीं बनना है, हॉस्पिटलस्थ नहीं बनना है, स्वस्थ बनना है, स्व में स्थित होना है, स्वावलंबी होना है. It might be for an individual, for a family, for a village community, for a population, but becoming swasth is people's health in people's hands. People's health in doctor's hands is not a safe situation. That gives doctor overwhelming power, and doctors' numbers are limited, so access to care becomes very limited, healthcare becomes very costly, and recurring attempt, innumerable tests and medicines and lifelong treatments. Instead, people should become self-empowered. Remember the logo of home-based newborn care, that empowered woman? That is swastha is our goal. So concept of health in India, the very word swastha. Swastha means, health means linked to autonomy and responsibility. It's an empowering concept. Swasthya in India is an empowering concept. It's not a dependence concept. So the Western model of medical care is dependence model. While Indian idea, not Indian practice. I must tell you, unfortunately, whether it is Ayurveda or any, in everywhere you find dependence. Instead of on doctor, it will be dependence on Vaidya. But we are talking not about dependence. We are talking about making people free of dependence. Health is freedom. Health has to be freedom because it is swastha. That approach is called, we call it Arogya Swaraj. Swaraj. Raj means not only power, but also responsibility, which means capability. So make people responsible as well as capable, empowered for taking care of their own health, which would mean really starting from prevention. How to live, how to eat, what not to eat, how not to fall prey to tobacco, alcohol, various addictions, how to do regular exercise, yoga. All this would be Arogya Swaraj. And if you fall sick, solution should be available within your own village and community. Arogya Swaraj. Now some of the questions, personal questions, which young people may have. Where should I go to make the best use of my education? My answer to this would be, go where the problems are and not where the facilities are. Places with facilities don't need you. There are plenty others aspirants. You are the last in the queue. Instead, go where the problems are. There is nobody else. You will be the first to provide care. You will become the pioneer. At least you will have the satisfaction of providing care to the people who don't receive from anybody else. So go where the problems are. Which health problem should I work on? Identify people's needs and not thrust upon them your priorities. The way we did with the sickle. I don't intend to downgrade sickle as a problem, but because symptomatic problem, sickle troubles less than 1% of the population. Most of them have no health manifestation. We doctors see only those who have serious problem and we think sickle must be very troublesome. But if you look at the whole population, most of them have sickle cell trait, which doesn't have any symptom. And so, select health priorities which people need. They may tell you that it is malaria. They may tell you it is backache. They may tell you it is fever. They may tell you it is high blood pressure. They may tell you it is difficulty in deliveries. They may tell you it is mental health problem. I don't know what they'll tell you. Ask them. Why imagine? Ask them. And what kind of healthcare should we provide? It should be health empowering model and not impoverishing model. Medical care bills are so huge, so astronomical. Even though I am a doctor, if I fall sick, my angioplasty was done in one hospital, I'll not name, and my bill was sent to me 8 lakh rupees. Ooh. As a voluntary person working in rural area, this was my 4-year salary. So, medical care has become very impoverishing. Some years ago, World Bank had made estimate that medical care bills make 7 crore people pushed below poverty line in India every year. So we have become one of the main cause of poverty generation in this country. It's because our approaches are so costly. Instead of that, instead of pushing people for technological, high-tech healthcare, begin with the village, begin with the empowering model in the village. And how to make larger impact? That is research with the people. I described you the whole process deliberately, that how to identify a problem, how to develop solution on it, how to test it, so that you generate evidence of its effectiveness. And if you generate evidence of effectiveness, not just your claims. We in the social sector often have this wrong habit of making tall claims. No substantiation. But we go on describing how great work we are doing. I don't know whether people trust us. Do they believe what we say? So we have to generate evidence. And not for the people, other people, but for being truthful, not being a liar. You have to really see what results my approach, my work is producing. So generate evidence. 9 out of 10 times you will fail, but that's good. We will know that we have failed. Otherwise, we will go on propagating a failed solution if we don't test. But if we test whether my work is having effect, test rigorously, then 1 out of 10 times I might find a solution which is a jewel. And it has then much larger impact than where you work. So research with the people. The last question, how to save myself? Several years ago, when there was famine in Ethiopia, very bad, 30 years ago famine, you see this photograph, a child very malnourished, completely exhausted. It has given the hope of survival. It is so weak that it rested his head on the earth and a vulture is waiting for baby to die. It's a cruel photograph. This photograph became world famous, and that year it received Global Best Photo Award. But it also puts responsibility on us. If there are children dying in this way, and if there are vultures waiting for their death, I cannot sleep peacefully. Jean-Paul Sartre used to say that I am responsible even for the wars of my time. Every human being has the responsibility of the whole planet, of the whole human race. And so, what is my purpose of life? As long as there are this kind of problem, not only this problem, but this type of problem, farmers are committing suicide, women being subjected to rapes and misuse and murder. Alcohol is generating havoc in rural and tribal area, but government is continuing to promote it. I can list a list of problems, but I don't have to list. Ask the people as to what their problems are. And actually, in those problems, these problems are my responsibility. Because I belong to the people. I didn't drop from heaven. I was born amongst the people. I grew up amongst the people. I derived everything from the people. Now I owe it to the people. That gives me the purpose of my life. The young generation, what should I do in my life? This is the most important question before the youth today. Today's youth has almost practically has got assurance that it will receive food. Madhukari magavi nahi lagnar hai. The real challenge now is, what do I do with my life? We have started a movement called Nirman to help young people find out social mission for their own lives. And so, search continues. This is not merely our organization's search, but this is a larger search. Search for human life's purpose. What people need to provide them that is my swadharma. That's my duty. Mahatma Gandhi and Vivekananda both have shown us this path. Daridra Narayan ki seva. That provides meaning to my life. Otherwise, everybody is born, everybody is going to die one day. I have to instill meaning into my life. There is no inherent meaning to human life. You have to choose and you have to give meaning to your own life. And it is by relating with others, taking responsibility for others and helping them to become empowered, that gives meaning to my life. Young generation, through Nirman and these kind of searches, I hope will find the purpose of their life. And if we want to change the world, the immortal words of Mahatma Gandhi, be the change yourself that you wish to see in the world. How can we preach others? How can we only say, "Ye jug har white hai, ye isme ye bura hai, wo bura hai"? We are the change makers. The change must begin with ourselves, and the change has begun. So you and I have all the power to change the world, because change can begin with yourself, and that's in your hands. Gandhi was miraculous in this respect. He gave simple solutions and simple methods which all of us, you and me, can practice. And so, our search in Gadchiroli and your search through Sewa International and everybody else's search about his own or her own life as to what is the purpose of my life? Where do I derive meaning for my life? It continues. This is again our organization, our email address and our website address and the Nirman address. I thank Sewa International for giving this opportunity to have dialogue with you and share with you my experiences and my thoughts on Arogya Swaraj. Thank you very much.
Thank you so much, Dr. Sir. Abhayji, this was absolutely enchanting, if I may say so, to begin with. And there are so many questions. I think, there are questions which people will now get as well, and I'm looking forward to some of our audience posting them as we speak. But fortunately, some of the questions had come in earlier. So I will start with a few questions, sir, and we would really love to hear from you. My first question, sir, to you is, and I'll start with what you said about your life. You spoke about, having a, in Marathi we call it Prerna Sthan. Your generation and maybe the previous generations had a Gandhiji, had Vinobaji, maybe a Jayaprakash ji. What are the Prerna Sthan that this generation should look towards?
They should look at the mirror and they should derive Prerna from their own self. There are two reasons why I say this. Great heroes and great Mahatmas are produced accidentally in the flow of history. You don't make them. They happen. If you read Arnold Toynbee, the greatest historian of 20th century, Toynbee describes how 50 different civilizations over a period of 13,000 years rose and fell. And he finds then one key. He says that when there are great adversities, challenges which might extinguish the entire civilization, some civilizations decay and degenerate. Some fight and rise. Which one? He says there comes a hero, a Nayak. So this is the hero Nayak theory of how societies either survive or they decay or die. Such heroes, such Mahanayak comes up once in 1,000 years. We were fortunate that just few years before we were born, there was a man like Mahatma Gandhi. About Albert Einstein very correctly said, when Gandhiji died, he said, generations to come will scarce believe that such a one in flesh and blood walked on this earth. So, we can't look at the past, at Gandhi and Vinoba and Jayaprakash or Vivekananda or anybody else. We have to become our own torchbearer. We might be small. We are small. But there are no lofty Himalayan tall figures now any longer in the world. Only Dalai Lama is left. I can't see any global other figure who is both spiritual as well as social. So, Bhagavan Buddha very rightly said, Atta Deepo Bhava. Apna deep khud baniye. So I think that's our responsibility. And fortunately, now literacy rates are much more better, education much better, and we all have access to knowledge. So we must become our torch bearers. A dependence model where we look for somebody else to become a leader and show us the path is a dependence model. Excuse me.
Sir, in your entire initial experiment and what you spoke, could you also let us know whether you think there is a difference between how it needs to be taken up for the urban India versus the rural India, or is it the same model which will work all across?
I would say a major part of that would work both for urban as well as rural. And you will be surprised when I read the history of public health. In year 1900, means nearly 120 years ago, New York City trained community health workers for maternal child health. So even in urban areas at that time, 120 years ago in the US, there were Arogya Doots. So in urban area, there are needs like hypertension, diabetes, obesity, backache, mental health problem. Instead of depending on doctors, which will be 100 times costly, a community health worker, home-based management, and most important, empower that person to take care of his own health. So that component, the principle would be similar. Maybe health problem would be different. They'll probably not work on newborn mortality or pneumonia. They'll work on something else. Problem would differ, but the principle and approach to a large extent would remain similar. Maybe hospital and doctor's role will be more in urban area because facilities are available. Secondly, the search for purpose of your life, that remains, whether it is urban or whether it is rural, it remains common.
Another question related to the model, the whole Asha model, the Ashok model, which is based on your Gadchiroli experiences. How much of that is dependent or not dependent on public government partnership? Can it be done? What is the importance of both being there, and how does it work, or can it be done without government participation also?
Look, the national program like Asha cannot be done without government's participation, but that's the issue of size. If you want to do it 9 lakh Ashas, obviously no individual or no organization can have that capacity. But if I am working in a one block, if I am working with 20 villages, I can as well work independently. If I can raise the necessary resources from public participation, I don't have to necessarily go through government. For example, whatever I described to you as search work was independent of government. Then government adopted it subsequently is a different thing. So at a small scale or at the moderate scale, we can do, social organizations can do it independently. And even I would say that is preferable because it's a Swalamban model. It is social-based model rather than government-dependent model. But if you are thinking about national, yes, then government is the best alternative.
And then again, sir, in terms of a little bit more clarity for our audience, in that entire model, how is the mix of the first, like you said, the Swalamban, the actual worker and his or her family, then the support of the community, and finally actual facilities, etc. What is the role that each one of these has played in your model or in the national model today?
Let me take another example because that is a better illustration. Tobacco and alcohol are major challenges in rural areas all over India, all over the world. Same in Gadchiroli, probably more in Gadchiroli because poor people succumb to tobacco and alcohol more. So we have done studies after studies in Gadchiroli and have found that people spend 373 crore rupees per year on purchasing tobacco and alcohol. But don't get surprised. Maharashtra people, population of Maharashtra spends 1 lakh crore rupees every year on purchasing alcohol. Now, for this kind of problem, you need a social approach. You can't say कि I'll work with one addict और मैं उसको डी-एडिक्ट करूंगा, व्यसन मुक्त करूंगा. कर भी दोगे, लेकिन वो टिकेगा नहीं. अगर शराब ऐसी बह रही है और गवर्नमेंट अगर हर दुकान में शराब सप्लाई कर रही है, तो बेचारा शराबी अपना कैसे संभालेगा अपने आप को? And so you need a social approach, and that's how we worked in Gadchiroli and finally got alcohol banned in the entire district. So there is a prohibition in district, but then we didn't stop at that. We knew that government के prohibition करने से जादू नहीं हो जाता है. You have to make it work, and make it work means then communities. So we have organized people in 1100 villages where people have stopped alcohol in their own village. We have also trained in every taluka people who manage addiction and provide addiction treatment. So a social model at the larger level, a community model at the village level, a community health worker to give solution at the village level, but finally responsibilities with the individuals and the family. That's how it works at multi-layered fashion.
So just a query which came up in my mind when you were talking, even the needs would change, this whole approach of asking what the people need change. Has that significantly changed in Gadchiroli? You've been working with such a great success for 30 years.
Certainly, you are absolutely right. The Gadchiroli to which we came in 1986 and today's Gadchiroli, there is a vast, they are poles apart. Roads have increased, education has increased, telecommunication, mobile phones, televisions have increased, motorcycles have increased. And so there are many changes have occurred. But economy primarily has remained same. Paddy cultivation and forest-based economy. Rural, tribal culture to a large extent has remained same. Dances, community living, closeness of tribal society, their dependence on the forest, they have practically remained same. So some aspects have remained same, but sizable other aspects have changed. And with that, the disease pattern has also changed. Now, even in Gadchiroli, where we have been working, child mortality is much less. Malaria is practically, I wouldn't say non-existent, but much better controlled. So several of these diseases are better controlled, but now diabetes, high blood pressure, stroke, and mental health problems, stress, depression, they are emerging. So the changes which occurred probably in the rest of India or rest of Maharashtra, maybe 50, 70 years ago, they are now entering Gadchiroli also.
Sir, coming to this trying period that we all went through as a society, I have two questions around it. One, did COVID teach us something else, and in your model give you some insights in terms of how we could have done it better, or could we do something more? And the second related question, which manifests in the way we are conducting today's program, is that the digital revolution is a revolution. How can we more effectively utilize such things for effective healthcare?
Look, the second aspect is now globally talked about, that's called digital health, or sometimes it's called mobile health. Mobile health doesn't mean mobile medical unit, but it really means using mobile phones for promoting health. And mobile phones make things, you just can't imagine. Look, there is a village called Murumgaon, 60 kilometers away from where we live, on the border of Chhattisgarh. One day, women from Murumgaon called me. They had caught one truck with illicit alcohol. And when they caught it, finally, all bottles, illicit bottles, nearly 27,000 bottles were finally confiscated. They were illegally being transported to Maharashtra, but the person escaped in a jeep. So I said, bottles तो मिल गई, आपने बहुत शौर्य किया, लेकिन वो आदमी तो भाग गया, वो कौन था? So those women, tribal women from Murumgaon, took out their mobile phone and showed me photograph of the jeep and the number that they had taken. Look how empowering it is. So mobile phones and digital technology can very dramatically change life in every aspect, including health. But it is so often talked about, and there is so much literature available that nothing I can really talk great about it. But your earlier question, in case of Corona, I must say it is easy to talk with the wisdom of hindsight.
Yeah.
But when it came, nobody knew what this disease is. Actually, as a medical person, on one side, I am concerned about Corona, but on the other side, hidden in me is a child which is so excited that a new disease was born right in front of my eyes. A new virus was born, a disease was born, and medical research progressed so fast that within 2 months of the appearance of this disease, Chinese scientists decoded its genetic code, made it available to the world. Tests were developed within 3 months. We understood how disease spreads within 1 year. Vaccine was developed, and now look, almost half of the world has been vaccinated. So we learned one power of research and knowledge. At the same time, politicians managed this epidemic very badly. The rigorous lockdown in China is inhuman. But the Britain took a sort of a relaxed approach. हो जाने दो, सबको बीमारी हो जाएगी तो सबको immunity हो जाएगी. They paid heavy price of that approach. Even in India, politicians managed it badly. This, of course, I am saying all the hindsight, but it could have been managed much better. So what we learn is that we have to be ready for this kind of waves and waves of infection in the future. New viruses will mutate. They will attack human society. Fortunately, science gives us capability of developing solution fast. But the politics and the social models don't give us that power to utilize it widely. Even today in Africa, only 15% people have been immunized. Such a tragedy. And so COVID has taught us a lot of lessons. In Gadchuli, when COVID came, initially, of course, nobody knew how disease spread, so there was terrible scare. We initially protected our staff. Then, through hospital, we provided care to the serious patients. But for the third wave, we developed a village-based model. And we developed home-based management of COVID. And our community health workers, nearly 90 community health workers have been treating COVID at home because people are so scared, they don't want to get tested because that leads to quarantine. So they hide it. So we said instead of hiding, get treated, quarantine in your own house, but don't test, but still get treated and quarantine in your own house. Our community health workers so far have treated nearly 10,000 patients of COVID at their home with not a single death, not a single death. So COVID can be managed in a different way. Now, fortunately, this wave of COVID is relatively mild. So it's possible to manage it at home. That's what we are experimenting.
I know there are so many questions. In fact, with the organizers' help and with your permission, sir, there are some unanswered questions, but we do also have to respect the time that we had mentioned. We will take the liberty of sending some of these questions to you, sir, so that when we get your views on it, we can share it with the people who had asked them. I always like to take this shortcut, as one says. There is so much that you have told us today. But, sir, if you want to leave one message, and it is across, there are people like me who are not so young today, but there are many youngsters as well. One message, sir, which you would like to leave our audience with before I ask Shyamji to propose the vote of thanks. One message from you, sir.
It would be same which Mahatma Gandhi gave to my father. Go to the villages of India.
Thank you so much, Abhayji. Shyamji, please, I request you to propose the vote of thanks. And after that, I will just make some short announcements. But Shyamji, over to you.
Right. I like Shubham to do that, but just the concluding, of course, but then vote of thanks. But before that, I'm delighted today to listen to Dr. Abhayji. We come from the same locality. As a matter of fact, Dhantoli, we the same part of the city of Nagpur, and his father was a known Gandhian, and of course, Sevagram. Even now, the diplomats who travel to Nagpur, I request them because I interact with some embassies in Delhi. I request them go to Sevagram so that you understand what the life of Mahatma Gandhiji was like. And this is how it has been. Back to villages, of course, is the mantra that Dr. Abhay Bangji has lastly given us. Beyond all his, thought-provoking talk and the examples he gave were most motivating. So I thank him very much. And Shubham, over to Shubhamji. But I did not do that because I had to drop in the meanwhile and join again because I had another diaspora engagement, Punjabi diaspora engagement that I was part of. So I'm sorry for that. Yeah, Shubhamji, yes, please.
Thank you, Dr. Abhay. When I had started my journey in the non-profit sector, the first thing my professor said to me is that you will have to unlearn a lot of things and you have to be ready for it. This entire 1.5 hours has been about unlearning, breaking a lot of my beliefs, breaking a lot of my own understanding, and I'm sure it has been the same for a lot of us. Thank you, Abhayji, for making us learn by unlearning what we have learned about development. Thank you so much. I look forward to visiting Sir sometime soon and being in your company and taking up this exam. Thank you.
Thank you. Thanks, everybody.
Thank you.
you.
And just one small announcement for our audience. Our next speaker is again somebody, and Abhayji, if you do get the chance, we would be very happy if you can join us for that. It always makes a lot of pleasure for us when illustrious speakers like you do come back and join us when we talk to other people as well. So our next person will be Jitendra Singh Shuntiji, a COVID warrior and a social worker. He has just been awarded a Padmashree also, like you, sir. He's the founder of the Shahid Bhagat Singh Sewa Dal, and they have been doing one outstanding activity in terms of helping cremate unclaimed bodies and immersing their ashes as per the rituals. And in the last 1.5 years of COVID, they've done this for 4,000 people. So that will be our next sort of guest. More details we will share soon. But thank you, everyone. Abhayji, thanks a lot. Kumar said, we will all be looking forward to, before the talk I mentioned as well, that I am anyways planning to be in Gadchiroli, and we will be so happy if we can get a chance to see what you're doing there. But with that, thank you, everyone. Namaskar, and stay safe, stay healthy.
Thank you. Thank you very much.